My name's Hasib Sidiqi. I'm a haematologist from Fiona Stanley Hospital in Western Australia. And today I'll be presenting on management of AL amyloidosis, an update in 2023. I want to thank the IACH for inviting me to present this webinar. I hope you all find it useful. We know that amyloidosis is really an umbrella term that describes a number of disorders, all that share a common pathophysiology. We have an amyloidogenic protein precursor that, for hereditary or acquired reasons, due to physiological changes, becomes amyloidogenic. These proteins misfold, form amyloid fibrils that form amyloid deposits and deposit in organs, causing organ dysfunction. And there are a number of different types of amyloidosis. Over 30 different types of amyloidosis have been described. But the most common one that the hematologist will face is light chain, immunoglobulin light chain amyloidosis. And probably the two most common types of amyloidosis that we are likely to see are AL amyloidosis and ATTR amyloid. And it's important to be aware of these two, particularly when it comes to trying to make a distinction between them, given some of the shared presentations that these two types of amyloidosis can present with. Immunoglobulin light chain amyloidosis is a disorder that is characterized by a plasma cell or B cell clone that produces amyloidogenic light chains that form these amyloid fibrils and deposit in a number of organs, causing organ dysfunction and toxicity. The median age at presentation is in the mid-60s with a slightly more male predominance. We know there are certain risk factors, for example, having a monoclonal gammopathy, and increasingly we are realizing the importance of genetic variations, particularly variants in the translocation 1114 that promote amyloidogenesis. And unsurprisingly, we find that translocation 1114 is found in up to 50% of patients with AL amyloidosis. The incidence is reported to be in the order of 9 to 12 per million person years. This is likely to increase a little as our ability to recognize and diagnose this condition improves. In terms of organ involvement, well, we know this is a multi-organ disease and almost any organ can be affected, but the classic organs that are affected are the heart and the kidneys, involved in anywhere between 60 to 70% of patients. But as you can see, multiple organs can be involved, including soft tissues, the liver, the autonomic and peripheral nervous systems. You know, some of these other manifestations that are very specific for light chain amyloidosis, such as macroglossia, are not very sensitive. They're only present in about 10 to 15% of patients. In terms of diagnosis, really the gold standard for diagnosis of AL amyloidosis is a tissue biopsy that demonstrates amyloid deposits via a Congo red stain with that typical, Congo red avidity with apple green birefringence under polarized light. However, once that tissue sample is identified, we don't stop there. There is a critical step in diagnosis of light chain amyloidosis, which is subtyping the amyloid deposits. Now, traditionally, we have relied on immunohistochemistry. The diagnostic sensitivity of subtyping amyloid deposits using immunohistochemistry varies depending on the centers that it is performed in and the level of expertise in those that are performing the immunohistochemistry. But we know that in the best hands, the diagnostic sensitivity can approach over 95, close to 100%. And there's a good study from the UK National Amyloidosis Consortium that has shown improved sensitivity and concordance with mass spectrometry by using immunohistochemistry techniques. There are, however, cases where immunohistochemistry is inconclusive, And for those cases, really, we need mass spectrometry. And this really has become a standard subtyping technique for patients with amyloidosis. It starts by identifying those Congo red positive amyloid deposits. So we still need that tissue sample to identify the amyloid. There is a laser microdissection step involving removal of those Congo red stains. There's an antigen retrieval step and a trypsin digestion step before running that sample through the mass spectrometer. This then is compared to a biobank of proteins found in human samples. And from there, we are able to identify which proteins are prevalent in that sample and get a definitive diagnosis of the subtype of amyloid. And this is becoming increasingly critical, given we are finding many patients, particularly in the older male population, presenting with amyloid cardiomyopathy, where there is a potential for wild-type transthyretin amyloidosis. And these patients often have a coexisting MGUS. Subtyping and therefore becomes critical to identify the specific type of amyloid and appropriate management. In terms of prognosis, really, we've traditionally relied on the Mayo staging system. Cardio biomarkers are critical in prognosticating patients with AL amyloidosis. The initial Mayo staging system was then modified to include the free light chain assay, giving us the Mayo stage 2012. And as you can see here, those with an elevated NT-proBNP, troponin T, and elevated free light chain ratios have a significantly poor prognosis, with patients with Mayo stage 4 disease having a median overall survival of approximately 6 months. What about response to therapy? Well, we categorize hematologic response based on the serum free light chain assay. And as you can see, patients who achieve a DFLC decrease of more than 50% have a partial response, and then we have a categorization for a very good partial response and a complete response. And the importance of hematologic response is that it is highly associated with survival. The deeper your response, the better your outcomes. In addition to hematologic response, we have categorizations for organ response. Given organ involvement is a hallmark and organ dysfunction is a hallmark in patients with light chain amyloidosis. And as you can see, we use the NT-proBNP and the degree of proteinuria to help us identify a cardiac and renal response respectively. Now, there have been some modifications or additions to these response criteria. We now have a stringent complete response criteria with a very deep improvement in the difference in the free light chain ratio. MRD testing is becoming more relevant in patients with AL amyloidosis, and of course, all future clinical trials are utilizing MRD as a primary or secondary endpoint. We are realizing that there is increasing prognostic importance of MRD negativity in this disease. One thing to be aware of in terms of organ response that I'd like to highlight, which this study showed beautifully, is that organ response in patients with light chain amyloidosis can take a significant amount of time. This study looked at the time to organ response after normalization of the free light chain ratio. And what you can see here is that the median time can often be anywhere between 6 to 12 months after achieving a hematologic response. And so we often are faced with a patient that has significant cardiac or renal dysfunction. We've started them on therapy, their light chains have normalized, but the organs have not improved. And as long as we've achieved a deep response, it's important to give the patient time to see that organ response manifest. Moving on to treatment of AL amyloidosis, and I think there are a number of important principles to consider when we're looking at treating patients with light chain amyloidosis with chemotherapy. And these can be somewhat different to patients with multiple myeloma, where really the disease burden is the major issue. And often we don't have as many end organ dysfunction or as much end organ dysfunction as we see in patients with light chain amyloidosis. So I think the basic principles are, number one, to reduce the causative monoclonal protein production. And of course, we want to do this as quickly as possible and achieve as deep a response as possible. And hopefully this will prevent further amyloid fibrillogenesis and deposition in organs. I think the second principle, which is really relevant to patients with light chain amyloidosis, is to tailor the therapy to the individual patient, in particular taking into account anticipated toxicities and the extent and degree of organ involvement. I think, as I mentioned, these patients have significant cardiac and renal dysfunction, and that can have a significant impact on the choice of therapy. And really, again, to highlight that point, the third principle is to provide optimal organ-specific supportive care. And this is where a multidisciplinary approach to these patients becomes vital, working in close conjunction with cardiologists in those with significant cardiac disease and the nephrologists in those with significant renal disease, ultimately to try and maximize both quantity of life, but also quality of life. Treatment options for light chain amyloidosis have significantly changed over time, but this graphic representation really highlights the fact that traditionally we have borrowed therapies from our experience in multiple myeloma, all focused on suppressing the underlying plasma cell clone that's producing the amyloidogenic light chain. And as you can see over the years, as these agents were found to be effective in myeloma, we subsequently studied them in light chain amyloidosis and found effective agents for the treatment of this disease. Nevertheless, compared to the number of FDA-approved medications for multiple myeloma, light chain amyloidosis really did lag behind. And I think this is both related to the nature of or rarity of the disease, but also the difficulty in recruiting patients to clinical trials in a cohort of patients that often have significant organ dysfunction. The last decade has seen a significant improvement in our ability to treat this condition, with a number of newer agents being found to be highly effective. So what's the approach to treatment? Well, this is the Mayo MSMART guidelines for the treatment of patients with newly diagnosed light chain amyloidosis. Mayo Clinic is a center that traditionally has performed transplants for patients who are transplant eligible for light chain amyloidosis. So in the transplant eligible population, induction would proceed with a daratumumab in combination with Cyborg. And really the plan would be to assess response after 2 to 4 months. And if at least a VGPR has occurred, there would be the option of a stem cell collection, followed by continuing on the Dara-Cyborg protocol, which we will discuss in a bit more detail. If the patients have failed to achieve a deep enough response, then the options of switching therapy or consolidating with stem cell transplant become available. In the transplant ineligible population, and in reality, the majority of our patients at presentation, unfortunately, due to the organ dysfunction, are transplant ineligible. Really, standard upfront therapy for this population involves the combination of daratumumab with Cyborg based on the Andromeda study. And really, the goal is to achieve at least a VGPR, if not CR, continuing on this protocol. And really, if you fail to achieve that deep response, then looking at alternative options or switching therapy to try and optimize outcomes based on deepening response it becomes next line therapy. So let's look at the data for daratumumab in light chain amyloidosis. Daratumumab, as we know, is a monoclonal antibody to CD38 found on the surface of plasma cells. It is been found to be highly effective in multiple myeloma, and early phase 2 studies showed a high CR rate in patients with light chain amyloidosis. And it was on the basis of these studies that the phase 3 Andromeda randomized controlled trial looking at daratumumab in combination with bortezomib cyclophosphamide and dexamethasone versus bortezomib cyclophosphamide and dexamethasone alone was formulated. As you can see, the study design here, there was a 1-to-1 randomization. After a screening period, patients received a combination of daratumumab with Cyborg for 6 cycles or Cyborg alone for 6 cycles, following which the cohort of patients receiving Cyborg alone went into an observation period. Patients on the daratumumab arm then continued to receive daratumumab for a total of 24 cycles. Primary endpoint was overall hematologic CR rate. Important secondary endpoints included modified PFS, which we will discuss, the organ response rate, time to hematologic response, overall survival, and safety. What you can see from the baseline characteristics of the cohorts on this trial is that this is very typical for a group of patients with this disease. I think the key thing that to keep in mind within this cohort is that a significant proportion of patients had Mayo Stage 3 cardiac disease, so over 30% in both categories. But otherwise, the groups were well matched. The results showed an overwhelming improvement in deep hematologic responses for patients receiving daratumumab in combination with Cyborg. So looking at the overall response rate, but in particular, looking at the CR rate and the deep response rates, what we find is that the patients receiving daratumumab had a significant improvement compared to Cyborg alone. And really, outside of just hematologic CR, looking at those other categories of response that have been incorporated now in some clinical trials, looking at an involved free light chain of less than 20 milligrams per liter, or a DFLC of less than 10 milligrams per liter, we find that patients receiving daratumumab had a significantly better response rate than those receiving Cyborg alone. This improvement in hematologic response was found across almost all subgroups, in particular patients with Mayo Stage 2 or 3 cardiac disease at baseline. Of note, organ response, predictably, given the deeper hematologic responses, was better in patients receiving the daratumumab. So here we see that the cardiac response rate was 41% in patients receiving daratumumab compared to 22% in those receiving Cyborg alone, as well as a renal response rate, which was 53% compared to 23% in patients receiving Cyborg alone. So the investigators created a modified PFS that included death or significant cardiac or renal deterioration or hematologic progression. So this was a combined or modified PFS of any of those events. And really, this showed an overwhelming benefit for patients receiving daratumumab control compared to the control group, with a hazard ratio of 0.58. In terms of toxicity, I think that overall there wasn't any unexpected adverse events of interest, but one thing to keep in mind, particularly I think given the immunosuppressive effects of daratumumab, which we're aware of, is that the rates of upper respiratory tract infection were higher in patients receiving daratumumab. Particularly significant given we still have significant viral infections, including COVID in some areas that are prevalent. I think something to keep in mind in a cohort of patients that, again, may have underlying comorbidities, underlying organ dysfunction, where these infections may become more significant. So to summarize the Andromeda study, the addition of daratumumab to Cyborg significantly increased hematologic response, organ response, and the modified PFS rate. This benefit was seen across all subgroups, including Mayo Stage 3 patients. The overall regimen was tolerable, had a predictable toxicity profile. And really, this was a landmark trial for light chain amyloidosis. Based on the Andromeda study, this regimen became the first FDA-approved regimen for light chain amyloidosis in 2021, and really it represents a standard of care as upfront therapy for patients with AL amyloidosis. So what about relapse disease? Well, this is a far more difficult population to treat, and really this is highlighted by the fact that there is no standard of care, there's very limited data, and the choice of therapy really is dependent on prior exposure and patient and disease factors, and often logistic factors in terms of access to drugs. If we look at the MSMART guidelines, they break it down into whether the patient has had prior daratumumab exposure. I think most people would agree that if the patient is daratumumab naive, then that would be a fantastic option to treat relapse disease. In the absence of that, a stem cell transplant, if they are eligible, can lead to deep and sustained responses. But if they are not transplant eligible, then really it becomes a bit more difficult. There is very limited data in this cohort, and really your choice of therapy can be determined based on what drugs you may have access to, but also important aspects such as the translocation 11-14 status, given some of the evidence for venetoclax coming out in this population. For patients who are daratumumab refractory and don't have translocation 11-14, if they've previously had bortezomib and are refractory to this as well, then really you're looking at other plasma cell-directed therapies. And again, we'll talk about some of the data behind some of those options. And if they aren't bortezomib refractory, then certainly Cyborg is an option to consider. So what about a stem cell transplant for light chain amyloidosis? Well, we're all aware of the early studies that really, unfortunately, led us to steer away from using stem cell transplant in patients with light chain amyloidosis. This was a study that was done in the early 2000s, and what we found is that patients who received a stem cell transplant did no better than those receiving oral melphalan and dexamethasone. This study was highlighted by a high early mortality rate in patients receiving a stem cell transplant, and I think that was a reflection of patients who had significant cardiac disease tolerating intensive therapy poorly. What we have found over time, though, is that with better patient selection, stem cell transplant remains a feasible option in selected individuals. This is a study from the Mayo Clinic that shows improvement in outcomes with stem cell transplantation over time, and in particular, a reduction in early mortality. And really that comes down to better patient selection. So avoiding those who have significant cardiac involvement, significant renal dysfunction, we're able to reduce the treatment-related mortality from 10 to 15% to well under 5%, and really trying to aim for that 2 to 3%. And what we find is that a significant proportion of these patients will achieve a deep hematologic CR. And what you can see from the survival curves, that those transplanted in the more contemporary decades have a significant overall survival with, an 80% survival rate, well above 5 years. So I think this is an important consideration for patients with relapse disease that have limited other options and that are transplant eligible, do not have significant cardiac dysfunction, and would otherwise tolerate a stem cell transplant. In terms of lenalidomide, there have been a number of phase 2 studies We know that it's an effective therapy in light chain amyloidosis with response rates ranging from 40 to 70%, depending on the study that you read. It can be combined with dexamethasone or cyclophosphamide. I think there are a couple of important things to be aware of when considering lenalidomide. Firstly, that the dose that's going to be tolerable in these patients is not the typical 25 milligram dose that we use in myeloma patients. Certainly, I'd consider 15 milligrams as the starting dose, and in some patients, maybe even lower than that. We know that patients with light chain amyloidosis and cardiac disease, there is a reported potential to potentiate clinical heart failure, and certainly a rise in the NT-proBNP in patients who are treated with lenalidomide that have significant cardiac involvement in light chain amyloidosis. But nevertheless, for those that are daratumumab and bortezomib refractory, this may be an option. Similarly, the next generation immunomodulatory drug, pomalidomide, has been studied in patients with light chain amyloidosis. And what you can see here is that a significant proportion of patients will achieve a deep hematologic response, including a proportion of CRs and VGPRs over time. The overall response rate ranges from about 60 to 70%, but it is an effective therapy in patients who are daratumumab and proteasome inhibitor exposed or refractory. Again, of note, tolerability may be an issue. I think most centers would recommend a starting dose of 2 milligrams for these patients prior to increasing it up to 4 milligrams, titrating that based on response and tolerability. So what about BCL2 inhibitors? We know that BCL2 is important in hematologic, in B cell maturation, but really in many hematologic malignancies, we have found B cell inhibition to be effective. And we have identified efficacy of venetoclax in patients with indolent lymphomas, but also the combination of venetoclax and other BCL2 inhibitors effective in patients with acute myeloid leukemia, but also in patients with multiple myeloma, particularly those that harbor the translocation 11-14 mutation. And given the high predominance of the translocation 11-14 mutation in patients with light chain amyloidosis, we have found that venetoclax is an effective therapy in this cohort. This was a small case series of patients from the Mayo Clinic that we looked at. Patients were treated with venetoclax with a combination of either dexamethasone or other myeloma anti-plasma cell agents. Doses ranged from anywhere between 400 to 800 milligrams. And what you can see is that there are a significant number of patients that are able to achieve deep sustained responses, even MRD negativity in some cohorts. This was further highlighted by this multi-center retrospective study that looked at over 40 patients from 14 different institutions across the United States and Europe. And what we find is a CR and VGPR rate of 63% in this cohort. So really deep responses are achievable with venetoclax-based regimens. But again, what you see here is that really this is more effective in the translocation 11-14 population, with the CR and VGPR rate being 78% in those that harbor the translocation 11-14 and only 30% in those that do not. So really, I think this is an agent that should be reserved for those that harbor the translocation 11-14 mutation. Again, you can see on these survival curves in this study that those with translocation 11-14 had a significantly better progression-free survival, no difference in overall survival, but low number of events to draw large conclusions on this. The French group have published some data looking at venetoclax in a very small cohort of 9 patients who were treated with upfront daratumumab in combination with Cyborg. So this is a problem that we are likely to see increasingly now that daratumumab in combination with bortezomib is really the standard upfront therapy. Really, the question is going to be, what do we do next when these patients relapse? And as you can see, even in this small case series of 9 patients, significant CR rate in those treated with venetoclax for relapsed light chain amyloidosis. So really, I think this agent requires further study in the relapse, but also potentially in the upfront setting, particularly in those that have translocation 11-14. So what's on the horizon? Well, I think novel combinations of drugs that, of anti-plasma cell agents, particularly given the plethora of anti-plasma cell agents that are being developed. In addition to that, looking at novel targets such as BCMA. And what about bispecifics and CAR T cells in patients with light chain amyloidosis? Well, this is an interesting, talking about novel combinations. This was a study that was conducted in conjunction with the IFM and the Australian Leukemia Lymphoma Group in Australia. This is now closed to recruitment, but this is looking at a combination of isatuximab with pomalidomide and dexamethasone. And I can tell you anecdotally, having had some patients on this study, that this really is a potent regimen, and we're eagerly awaiting, the results of this study. But these are the kinds of combinations I think that are really going to change some of our ability to treat particularly relapsed disease. There are other combinations being studied, such as daratumumab, pomalidomide in previously treated AL, and a host of other agents that are being looked at. Well, what about bispecific therapy? I mean, bispecific therapy is highly effective in patients with multiple myeloma. And really, the question is, can we transfer that to patients with light chain amyloidosis? I think one of the critical things for patients with light chain amyloidosis is going to be tolerability. These patients often have cardiac and renal involvement, as we've mentioned, and tolerability of events or toxicities such as CRS and ICANS may be a more significant issue in this patient population. Nevertheless, this is a very small case series of patients treated with teclistamab that was published this year. These were patients primarily with multiple myeloma and amyloidosis, although one patient in this cohort had light chain amyloidosis only. But what they identified was that patients responded. Some patients had deep responses that were sustained. There were cardiac responses observed. And really, this just highlights that these agents have a potential in this disease. We know from our experience in multiple myeloma that they are able to produce deep and sustained responses. And those deep and sustained responses are critical for organ response in patients with light chain amyloidosis. So I certainly think that these agents are going to be studied in the future in patients with AL amyloidosis. So what about other potential therapeutic strategies? I mean, thus far, we've primarily looked at reducing the supply of the amyloidogenic light chain by, targeting those pathogenic plasma cells in the marrow. Well, what about targeting the amyloid deposits? This is an area that increasing study or that we are increasingly seeing studies looking at trying to remove amyloid deposits that have already formed on organs. And in this space, we have a couple of antibodies that are now, advancing through the clinical trial stages. The first that I'd like to mention is KL101, which is an anti-light chain or fibril antibody. It really is designed to bind onto the amyloidogenic light chains that have formed these fibrils that have deposited in tissues. then recruit macrophages and neutrophils and help solubilize those amyloid deposits and get rid of them. What we know from this early phase 1 study of this agent is that it is effective in improving cardiac function and inducing what we would call as an organ response. As you can see from this image, the percentage change in the baseline NT-proBNP, a significant proportion of patients treated on this phase 1 study showed a significant improvement in the NT-proBNP. And it is based on these results that the phase 3 clinical trial has been open and recruiting, looking at this agent in combination with bortezomib, cyclophosphamide, and dexamethasone as upfront therapy for patients with advanced cardiac light chain amyloidosis. So really, this is Mayo stage 3A, 3B patients. So this is a placebo-controlled trial, 2-to-1 randomization with the primary objective of overall survival. And really, you know, improving organ dysfunction, removing amyloid from organs is the holy grail in amyloidosis. And I think that, you know, agents like this have the potential to really alter the natural course of the disease. So it'll be very interesting to see the results of these clinical trials as they move forward. Birtamimab is another antifibril antibody that was initially studied in a phase 3 randomized controlled trial that really was ceased due to futility. However, a subgroup analysis of patients on that clinical trial really identified that the target population should really be patients with advanced cardiac disease. So what you can see here is that survival was significantly improved in patients who received birtamimab who had Mayo stage 3 disease compared to placebo. And again, although the overall study was stopped due to futility, at that stage the study included all comers. But because of this subgroup analysis and this signal in this very difficult to treat population, the phase 3 clinical trial looking at birtamimab plus standard of care chemotherapy in patients with Mayo stage 4 light chain amyloidosis is currently up and running. So again, this is a randomized controlled trial of upfront therapy in patients with advanced cardiac light chain amyloidosis. It's a placebo-controlled trial, and I think you know, this is the kind of clinical trial that we really hope will make inroads into the treatment of these patients who, as I mentioned earlier in the talk, have a median overall survival often of well under 12 months. So to summarize, I think accurate subtyping is a critical step in appropriate management of patients with light chain amyloidosis. I think this is going to become increasingly relevant given the increasing numbers of patients that are being diagnosed with wild-type transthyretin amyloidosis. This is particularly relevant in older males who have traditionally had heart failure with preserved ejection fraction, but the increasing recognition of wild-type TTR amyloid in this cohort also raises the possibility of light chain amyloidosis, because often it is this same cohort of patients that have a monoclonal gammopathy. And this is where subtyping becomes critical. So I think, you know, that's a critical step in diagnosing these patients appropriately. And really, as I've mentioned previously, whilst we've traditionally relied on immunohistochemistry, mass spectrometry has rapidly become the gold standard for accurate subtyping of these patients. The goal of therapy in these patients is deep and sustained hematologic responses, which hopefully will translate to organ responses. So we know that deep responses improve survival, and really the rates of organ response are significantly improved the deeper our hematologic response is. Daratumumab in combination with Cyborg is a standard of care for newly diagnosed patients with light chain amyloidosis. Therapy for relapse disease is tailored based on prior exposure, patient tolerability, and disease factors. This is an area where really, data is limited in terms of guiding us on best next line of therapy, and really is an area of unmet need. Novel anti-plasma cell agents require further study in this patient cohort, and I think that over the next decade, we are likely to see the bispecific agents, some of these novel anti-plasma cell agents such as selinexor and CAR T-cell therapy enter the space of therapy for light chain amyloidosis. And really, I think antifibril agents, which we've discussed just at the end there, I think these are really a novel way or a novel approach to treating patients with light chain amyloid. Often our hands are tied by the organ dysfunction that these patients suffer. Having an agent that can potentially induce a rapid and sustained organ response may really alter the natural course of this disease. Thank you for listening.